Good evening, everyone, and welcome to Emirates Pediatrics and Neonatal Society. My name is Dr. Hiba, and I'll be your moderator for this evening. On behalf of Dr. Munir Al-Mazmi, who is the president of Emirates Pediatric and Neonatal Society, I would like to welcome you all, our faculty, our organizing committee, our attendees, without which we could not have established this webinar series today. We look forward for you to enjoy the talk. Basically, our webinar series would run over a couple of months until the end of year, and then hopefully next year as well. And then we'll welcome you again to attend our physical ethnic conference, hopefully by November 2021. Today we have two esteemed speakers, and you notice that the theme of our speaks are mainly pediatric and neonatal, so we'll have a topic of each, and they're mainly intensive care related, but then you will have a variety of topics as we go through. So I'd like to introduce our first speaker. Our first speaker is Dr. Anwar, who's a renowned consultant in oral and maxillofacial surgeon who had established the first cleft and palate center in UAE and who's currently practicing at the Jalila Children's Hospital. He'll be speaking to us today on the management of neonatal and pediatric upper airway obstruction. And our next talk will be about NAVA ventilation, and the speaker is Dr. Ahmed Elajab, whose talks are always a pleasure to listen to. He's specialized in perinatal and neonatal medicine, and he's currently practicing at the Jalila Children's Hospital and NICU. So without further ado, I'd like to invite our first presenter to speak. Thank you.
Thank you very much, Dr. Hiba. I would like to thank to extend my thanks and gratitude to Emirates Pediatric and Neonatal Society for inviting me to this webinar meeting. As discussed, my topic today is management of neonatal and pediatric upper airway obstruction, a team approach. As a background, I would like just to emphasize on the differences between the neonatal upper airway and an upper airway of an adult. That in neonates, larynx is located higher, which causes the tongue to sit more superiorly and closer to the palate, to the soft palate, of course. They have stiff and relatively large epiglottis. The tongue is larger in proportion to the size of the mouth. And they have a poorly developed cartilaginous integrity, allowing for more laxity throughout the airway. But despite these differences, infants tend to maintain their airway patency via a fine balance of pharyngeal and lingual muscle tone and position. So during normal respiration, diaphragmatic contraction causes a suction force with an effect on pharyngeal wall to collapse. But this pharyngeal wall collapse doesn't happen because the pharyngeal wall patency is maintained by a complex mechanism or pharyngeal dilating muscles, which will counteract this suction force, preventing the airway from collapse during inspiration. So this requires a central coordination of diaphragm, the pharynx, tongue, and laryngeal muscles. And any disturbance in the integrity of this finely tuned system can cause obstructive apnea. So neonatal obstructive airway, as we know, is a potentially lethal condition. The causes for this can be neurological, can be respiratory, and can be structural. I'll be concentrating more on, when it comes to treatment, on the structure, which is the microretrognathia. So if we look at the schematic illustration which I have put there, you can see that the muscles of the tongue are connected to the mandible. So if we have a mandible in anterior position, Then we have the genioglossus muscle also in anterior position, and the tongue in anterior position. And in case of the retromicrognathia, the tongue is posteriorly displaced, causing glossoptosis and obstruction of the oropharynx and the hypopharynx. And this was first described by the French dental surgeon called Pierre Robin in 1923. So Pierre Robin, he described a constellation of findings, which is known as Pierre Robin sequence, which is a combination of micrognathia, retrognathia, glossoptosis, and a U-shaped cleft palate. The cleft palate should not always be there, but most of the time, these infants has also born with a cleft palate. So upper airway obstruction with resultant respiratory insufficiency and feeding difficulty is a result of this constellation. There are also other conditions which are also presenting with this problematic upper airway due to the micrognathia of the mandible, as tissue colon syndrome and Nagel syndrome, and many other. So for management of the neonatal upper airway obstruction, the common practice is that the primary caregivers, whether it is a neonatal intensivist, or in the pediatric side when they're a bit older and having upper airway obstruction, is that after indication of signs of respiratory distress, the infant, the newborn, is shifted to NICU for respiratory support, which can be in terms of simple oxygenasal support by nasal cannula, but can go up to intratracheal intubation. And the first classical surgical consult is to ENT, asking for the possibility of tracheostomy. So what's the role of the educator? My talk this evening is about, do we do tracheostomy? Should the first surgical consult be for ENT for tracheostomy? Is that a good practice? So my role is to present and elucidate other treatment options available as primary to symptomatic upper airway obstruction in these cases. Here we have an example, the illustration. You see the photo of a child which was tracheostomized, and when I took the history from the father, this was a child which could easily be managed just by postural treatment, but he was had a tracheostomy with delayed cleft palate repair to the age of almost 1.5 years, as I did. This was a case that, in my opinion, was not the case for tracheostomy. So what I want to emphasize on that for knowing how to treat these kind of upper airway obstructions, we need a team approach. So we should have a multidisciplinary approach to evaluate these patients. It's very important to know that not all infants with micrognathia, retrognathia are symptomatic. A good number of them are totally asymptomatic. And we should know that infants with symptomatic airway, a standard protocol for diagnostic workup is required to assess the background and the reason for the upper airway obstruction. And a result of this diagnostic workup would assist in deciding the most appropriate management plan, whether surgical or non-surgical. So within this workup is the radiography as usual, which is very important. One can do CT, the facial skeleton, can be cone beam CT, which has less radiation. And what information we can obtain from that is to know the maxillomandibular anteposterior relation. As you see in this infant, there is a huge discrepancy in the anteposterior relation of the mandible. The mandible is severely retrognatic with the tongue almost pressing towards the posterior pharyngeal wall, obstructing the upper airway. And we can also know the anterior posterior position of the tongue we can do a 3D reconstruction for our surgical planning. If we come to the conclusion this is a surgical case for resolving the upper airway, and the on CT scans, we can also measure and calculate the 3D functional airway volume pre and post-operative, and its correlation with the clinical parameters as apnea, hypopnea index, pre and post-op. Another team member in this multidisciplinary team is the ENT role. The endoscopic examination of both upper and lower airway is of great value to identify other causes for patients' obstructive airway symptoms. We want to know that this is this a true upper airway obstruction, or there are other supraglottic or subglottic lesions, example, choanal atresia, tracheomalacia, airway hemangioma, etc. And they have a role also to play if they have diagnosed that this is a true upper airway obstruction with glossoptosis through their endoscopic examination of the oral and hypopharynx. Also, they can assess post-surgically, kind of before extubating the patient, that the upper airway is now patent, so the child can be extubated. So they have a role to play both pre and post surgical management of them if required by the maxillofacial. The pulmonology has also a very important role here to play. The pulmonology role is, if you see the clinical scenario that we move the mandible forward, as we call it, through a mandibular lengthening procedure of what kind it can be, or we do a glossopexy, fixing the tongue in anterior position, resolving the posterior crowding, and still the child has apnea. So this means that surgical failure. That's why the pulmonology has a very important role to play in the pre-surgical evaluation assessment of patient to rule out other central causes of sleep apnea, as apnea of prematurity, which is common. It's like 50% of the premature infants has this kind of prematurity, which is like that the respiratory center is not mature, and they have a burst of breath followed by periods of shallow breathing or even stop breathing. And usually this fixes itself within a few weeks. Another condition can be the infant sleep apnea, which is a sleeping disorder, sleep like related breathing disorder, in terms of that there's a reduction or even pauses in breathing that occur during the infant's sleep. This can be both of mixed and peripheral obstructive nature, and majority of these sleep apneas are of mixed character. That there is a central apnea that is followed by an obstructive apnea. Another condition, which is the quite rare condition, is a congenital central hypoventilation syndrome, which is a disorder of the autonomic nervous system, that the infant or the child hypoventilates, like leading to hypoxia and accumulation of carbon dioxide, which happens mostly during the non-rapid eye movement sleep. This accompanied also as the symptomatology by cyanosis during the sleep. So these needs to be ruled out. So a sleep study throughout other patterns of apnea that would contribute to surgical failure is important. In this team also, the GI has a role to play. we know the problem with GERD and the feeding problems. The upper airway obstruction usually creates a hypermetabolic state due to child's repeated attempts to clear the airway obstruction, which in combination with poor feeding often manifests as failure to thrive. And infants with micrognathia tend to have also swallowing abnormalities because of abnormal pharyngeal and tongue movement, leading to increased risk of aspiration and inability to tolerate oral feed. So I discussed a couple of studies with you showing these relations in this group of patients. So Genevieve et al. In 2001 conducted a prospective studied the oral and esophageal motor function in children with Pierre Robin sequence without any additional neurological symptoms. This means that they were isolated Pierre Robin sequence, and they found esophageal monometric abnormalities in 50% of the children as lower esophageal sphincter hypertonia, failure of lower esophageal sphincter relaxation at deglutition, and esophageal dyskinesia. So they concluded that oropharyngeal motor disorder is present in Pierre Robin sequence and tend to spontaneously regress around 1 year of age. Another study also conducted by Baudon in 2000 evaluated suction and coordination between oral and pharyngeal phases of deglutition in 28 Pierre Robin sequence infants by using suction swallowing electromyography. They also used esophageal manometry to study lower esophageal sphincter, body, and upper esophageal sphincter function. Anwar was compared with manometry of 16 infants with GERD. So the findings were that electromyography showed incoordination of sucking and swallowing in 24 out of 28 infants. All infants showed manometrical disturbances as incomplete or asynchronous lower sphincter relaxation and asynchronous upper sphincter relaxation. And they had also higher resting pressure of both lower and upper sphincter than GERD. So we know that dysfunction of the motor organization of the tongue, pharynx, and esophagus leading to difficulty in coordination of sucking, swallowing, and breathing increases the potential of severe GERD and leads to NGT feeding and tube feeding. Thus, early airway intervention can resolve feeding problems and GERD. We should also understand that GERD per se can also worsen the upper airway obstruction in terms of creating irritation of the airway, edema by the repetitive reflux. That's why, so adverse effect of untreated severe GERD in Robin sequence is exacerbation of the obstructive airway symptoms by causing severe inflammation of neonatal trachea and failure of the surgical intervention due to persistent postoperative respiratory insufficiency and aspiration. Thus, we need to do a comprehensive evaluation required through manometry and 24 hours esophageal pH monitoring. I always say to the team, which I lead for the upper airway, that in these cases, in these patients, the Pierre Robin and a patient with upper airway obstruction, we should be very aggressive in treating GERD because GERD creates and aggravates the problem of upper airway. I had a very good example just a couple of months ago, a child who came to us, to Jalila, a precious child. The couple, this was the first child for the couple after, I think, 8 or 10 years. Child was having retrograntia, but very stable, was breastfeeding, no cleft palate, was breastfeeding the first 3 weeks. And then suddenly he came in with cyanosis and respiratory distress. And when I saw the child and evaluated him, I directly could understand that he had no upper airway problem because he was very comfortable on the lateral position, no distress, no symptoms, and could obtain oxygen saturation above 97. But as soon as you tried to feed him, he went into obstruction and cyanosis and respiratory distress. And that was confirmed by the ENT. When they did the endoscopy, they found that he had severe edema of the upper airway, of the hypopharynx. That's why treating GERD in this group of patients is very, very much, very important. And we should be very aggressive in treating GERD in this group of patients. So he was then shifted to pump feeding and was started on proton pump inhibitor just to resolve his edema and for a period till he comes out of this. So the airway management now, after getting the input from the team, which has been both the ENT, GI, pulmonology, and our radiological assessment of the patient, still the overall clinical impression of the patient is the most important parameter in deciding in decision making how to treat this patient after incorporation of the data obtained through the multidisciplinary team approach. So the primary goal of this team approach is to know whether the case can be managed through a non-surgical approach or surgery. So who are the patients who are, which patients are now a good candidate for non-surgical? We can say that indication for non-surgical is for patient not having any imminently threatened airway, that they have been like having a little bit of a sign of distress, but being like resolved when they have been put on side, but the parents has been very uncomfortable with this, and they bring the patient to us, and we by just the trial of putting the patient on the side, we notice that the patient is stable, and we can also establish a feed either through a normal feed or through an NGT feed, but would not require any management for the airway. So the treatment goal is to manage the patient until postnatal mandibular growth autocorrects the anatomical deformity and ultimately the upper airway obstruction and associated feeding difficulties. So postural treatment criteria to fit into this management plan: child with this difficulty eases and breathe comfortably when turned from supine to prone or lateral position. Personally, I like a lateral position, not the prone, because in the lateral position, you can assess the child's sign of upper airway much better than the prone, like the suprasternal retraction, the pex excavator, etc. And another thing is that patients should be educated. They should understand the rationale behind the postural, the changes. They should be educated in signs and symptoms to look for in the event of any respiratory deterioration and how to respond to it. And they should understand the importance of regular follow-ups that we decide for the patient. So when do we go for more advanced treatment? Is when the postural treatment is when they fail. So next treatment level is the nasopharyngeal airway, which is indicated when, in spite of the prone position, child is having episodes of obstruction or hypoxia, cyanosis, and oxygen saturation below 90. So what does the nasopharyngeal airway do is that the anterior displacement of the base of the tongue by the tube serves as a stent to open the upper airway. The nasopharyngeal airway, the treatment has been there for a long time. It was first described, suggested by Routledge in 1960 as an adjunct to other modalities, and then later by Extrup, by other authors. But most authors advocated the use of NPI, nasopharyngeal intubation, as a temporization measure in the first few days of life, then to be replaced by either glossopixy or tracheostomy. So this was only a temporization before surgeons were there to do their surgical management of the upper airway. However, in 2001 and 2008, these guys described the NP technique as a management of the severe respiratory difficulties, and not just as a temporization and before a surgical management was established. So this, the protocol of NP nasopharyngeal airway or intubation is based on that we take a nasal tube, an ivory soft tube of size 3.0, 3.5 usually. I rarely use less than this. Yet it had happened that in maybe a single case I use a size 2.5, but usually 3 fits well, and 3.5 also is usable. I cut it at the 9 centimeter length. It works always. If you measure it, you will find that this is the appropriate one, the length to use. And then we put a tape around the last centimeter of it, make the tube bulky so it does go into the airway. And then we prepare a 4 centimeter long micropore tape, which we divided to put around the tube, and then undivided onto the nasal bridge. Is inserted after lubrication with gel or Vaseline, and then I take a thin thread of a patch of gauze, hold in front of the tube, and it should move out during child's expiration. Otherwise, then tube is not patent. We have to take it out, check it for flushing through, check that it's not blocked, and the tube should ideally and just slightly above the epiglottis. Tube is kept always for 24 hours. We don't take it out. So the nostril will adapt to it. After 24 hours, we take it out, we flush it, we clean it, and then we insert the same nostril always. So this is based on that we change the tube after 7 days. We can change it also more often, the tube, to put a fresh one, and we teach the parents how to use this technique. And usually they stay for us for 3, 4, 5 days. They master this technique, and we check that they have done it, yes, many times under our supervision, and then we send them home and we bring them back for follow-ups to see that everything is going well. And if everything is well, then we call the child back when the child is 3 months old, admit the child, remove the tube, monitor, and check that the child really needs the tube or not. Usually by the age of, between age of 3 and 4 months, child is out of this condition and they don't need tube anymore. This is a case which was referred to us the end of last year from one of the private hospitals in Dubai. It was on CPAP when she arrived, and I inserted the nasopharyngeal tube. After a few minutes, she became totally calm, not crying, and slept. After 2 days, full oral feed was established through bottle. And on the 5th day of admission, she could be discharged home after training the mother on this protocol. So when it comes to surgical management, is for cases where the nasopharyngeal intubation has failed to maintain a good oxygen saturation. So our target for nasopharyngeal airway is that we should have a saturation of 90 and above. If we have it, then we are happy with that. If child is desaturating below 90, then the nasopharyngeal intubation is not appropriate, and we should think of surgical management. Our surgical repertoire of procedures is glossopexy, mandibular lengthening with mandibular traction, mandibular distraction, and tracheostomy. So I take you through these techniques and procedures. We have the glossopexy, that's fixing the tongue into the lower lip of the mandible, stabilizing the anterior position, so we can resolve the posterior crowding and upper airway. This was first described by Douglas in 46, and then Aragomaso in 92 modified Douglas technique. An advantage of the glossopexy is that it's a relatively short procedure time, is relatively low in cost, low in perioperative morbidity, immediate improvement of upper airway, improves feeding as a result of the airway improvement, and no need for long-term home care. The disadvantage is that it's a two-stage procedure requiring second surgery to release the tongue and reconstruct the tongue and the lower lip. Long treatment duration, as attachment of the tongue usually done together with soft palate repair around 1 year of age, and it can cause with feeding difficulty because of the lack of tongue movement. Complication, wound adhesions and disruption leading to acute airway obstruction, tongue laceration, injury to wharton duct, and scar deformation of lower lip and floor of the mouth. So the next surgical management level is mandibular traction, which I like in certain cases good. It was described by Stelmash in 57 and has been also modified. Is a non-osteotic technique based on anterior posterior advancement of the mandible by promoting surgical growth of the mandible. Is indicated in 50 to 20% of the Pierre Robin sequence where nasopharyngeal airway fails to resolve the upper airway obstruction. So what we do, we take impressioning of the lower jaw, we fabricate special tray for fine impression of the silicon, fabrication mandibular splint as you see in the illustration. We put a fracture plate of 2.0 and we do through a circummandibular wiring fixing this to the mandible, and child then shifted in NICU where you put this, as you see, the pulley system with weight in a feeding bottle. We start with 50 gram, and then when we increase within the 2 weeks to 200 gram. And this is the result before child was extubated. You see how much the mandible has been advanced. So the treatment is 2 weeks active and 1 week's retention, but can extend up to 5 weeks, and usually remove the splint in the NICU just under local anesthesia. This has worked for me to bring 3 child out of a ventilator. Another level of treatment, which is the more finer treatment, but more extensive, is distraction osteogenesis, which was first described by Russian orthopedic surgeon Gabriel Izarov in 50s as a procedure to lengthen long bones. But since early 90s, the technique has been adapted to the craniofacial skeleton and was initially used for cases such as hemifacial microsomia and bilateral treacher Collins syndrome. This is based on creation of mandibular osteotomy at the angle of the mandible, where the distractor is fixed. This is an external, can be also an internal distractor. The distractor starts immediately with a rate of 1.5 to 2 millimeter per day until the maxillomandibular balance is obtained, and it can also go with some slight overcorrection. So a consolidation period of 6 weeks, the action will move the tongue to a more forward position, resolving the posterior crowding and upper airway obstruction, and this works well in 90% of the severe cases of the Pierre Robin sequence. This means that there are 10% of the severe cases doesn't respond to this and would eventually require tracheostomy. So a complication of it is infection, non-union, device failure, facial palsy when you do the external approach through submandibular incision, and numbness of the lower lip, the screw going to the mandibular canal, and so forth. So the tracheostomy is indicated in settings where neither one of the above mentioned non-surgical and surgical intervention would prove to be successful. Case of severe laryngomalacia, severe trachomalacia. In many centers, especially in the US, tracheostomy used for the very complex cases where there are many abnormalities. These cases usually look at as more adequate for tracheostomy rather than other upper airway obstructing management level, surgical level. So the complications: tracheal stenosis, tube displacement, tube obstruction, pneumonia, speech impairment, and language development. So in conclusion, with the diverse range of proven treatment options available to the multidisciplinary team, tracheostomy should be considered the plan of the last resort. That was what I was planned to say today. I would like to thank you.
Thank you, Dr. Anwar, for a lovely presentation.
Thank you very much. Thank you.
It was highly informative, and I'm sure you get a lot of questions towards the end. Next is Dr. Ahmed Elajab. I'd like to invite you to speak, so you can have the mic.
Thank you very much. Welcome to the second lecture in this webinar. I'm going to talk about NAVA, or neurally adjusted ventilator assist in the NICU. No conflicts of interest. In this presentation, I will go through a brief introduction. Then I will discuss pneumatic synchronization and NAVA synchronization. And after that, I will talk about principles, settings, and weaning of NAVA. And at the end of the presentation, I will talk a little bit about the evidence base of using NAVA in the NICU. NAVA, or neurally adjusted ventilatory assist, is a mode of ventilation that uses the electrical activity of the diaphragm, or what we call it EDI. So NAVA is applicable whenever you have intact electrical signal from the brain to the diaphragm, and as far as you can detect this electrical signal at the level of the diaphragm. NAVA allows patient to initiate and terminate the breath to determine peak respiratory pressure and enabling flexible ventilation with breath-to-breath variability. As we know, synchrony contributes to the effective ventilation. But in neonatal population, sometimes synchronization is difficult due to high respiratory rate, short respiratory time, and also low tidal volume. The ideal synchronized breath needs to be synchronous with initiation, size, and termination of the breath. But looking to the different modes of conventional mechanical ventilation we are using the NICU, we just synchronize the initiation of baby breath with the ventilator. We are deciding for the BIB, we are deciding for the I time, we are deciding also for respiratory rate. So we are deciding for the size and termination of the breath. Even the synchronization of initiation of the breath with the ventilator sometimes happens late. We know the initiation of the breath occurs by generating the electrical signal as the level of the brain stem, and this electrical signal is transmitted by the phrenic nerve to the diaphragm, leading to the diaphragmatic excitation, diaphragmatic contraction, and then chest wall and lung expansion, and eventually leading to change in the pressure, flow, and volume of the airway. So if you are using a pneumatic sensor or flow trigger sensor, you will detect the initiation of the breath at the level of the airway. And if you are using NAVA catheter and you are detecting the electrical activity of the diaphragm, then you will detect the initiation of the breath at the time of the diaphragmatic excitation, which is a little bit earlier. This pulmonary graphic by Stein demonstrates some inaccuracies of pneumatic synchronization when compared with NAVA synchronization. The wave in the bottom of the screen here, it represents the electrical activity of the diaphragm. Then the wave on the top of the screen in the yellow color it represents the pressure wave. And this patient actually in SIMV plus PS. And then we have this superimposed wave, which represent the estimated pressure if patient using the electrical activity of the diaphragm. By looking here, you see there's no electrical activity, but still the flow sensor or the pneumatic sensor is triggering the breath. So this is most likely auto trigger. Then here, the breath should be started here, but with using the pneumatic sensor, it is start here. And this is the size of the breath by the electrical activity, but we provide only this much of BIB, and the breath terminated here, while if you are using the electrical activity, should be terminated here. Here also, initiation of the breath is okay, but the volume is, the pressure is larger than the pressure required if compared with the electrical activity. Here we have the electrical activity, but we don't have pneumatic trigger. So this trigger is missed. So from this graph, we can see these problems of auto trigger, these problems of synchronization with initiation, termination, and also this problem with the size of the breath in pneumatic synchronization. As I mentioned, NAVA is applicable whenever you have intact electrical signal from the brain to the diaphragm, and as far as you would able to detect the electrical signal at the level of the diaphragm. In NAVA, we are detecting the electrical signal by using the NAVA catheter, which is electrode embedded in a special nasogastric tube. You need to select the appropriate size. This is by knowing the weight and height of the baby. And then you need to calculate the accurate measurement of the nasogastric tube. This is done by what they call it next. You measure from the nose, earlobe, and then to the xiphosternum. And this is the calculated length of the catheter. If you want to insert the catheter through nasogastric or orogastric, then this specific equation and factors you need to multiply these numbers on this major length to get the calculated length of the NAVA catheter. After the insertion of the catheter and starting the NAVA module, you need to make sure that the position of the catheter is accurate. As we mentioned, the detection of the electrical signal at the level of the diaphragm is crucial for the NAVA ventilation. So by looking to the screen in the ventilator, you look to the ECG waves, you have to see this type of regression of P and QRS wave from up to bottom of the, from up to lower, from the first to the fourth ECG leads. And then you need to see this blue color in the middle two ECG leads. If the blue color, for example, in the upper or in the lower, you need to adjust the catheter till you get the blue color in the middle. And then after that, eventually you get this electrical signal of the diaphragm. This specific terminology to NAVA ventilation, EDI minimal, which represent the tonicity of the diaphragm or the remaining pressure in the lungs, which prevent the lungs from de-recruitment. And then we have EDI trigger, which is the minimal amount of increase in electrical activity of the diaphragm to be recognized by the ventilator that this is a breath. And then we have the EDI peak, which represent the size of the BIB or the size of the breath. So if you have EDI minimal 0.3, and then you got EDI trigger, you set the EDI trigger on 0.5, and you get EDI, and you get the electrical trigger, you reach 0.8, then the breath will start here, and the BIB is going proportionally with the electrical activity till 70% of the electrical activity, then the machine will terminate the breath. So the BIB delivered is based on the amount of the electrical activity generated by the diaphragm. The BIB is generated until the electrical activity decreased by 70%, and then the breath is terminated. The neonate by reflex control of diaphragmatic activity determines BIB in inspiratory and expiratory time for each breath and the respiratory rate. After insertion of the NAVA catheter and confirming the position, then you need to set these parameters to start the NAVA ventilation. Start with setting by setting the EDI trigger. Usually for EDI trigger, we keep it on 0.5 microvolt. But if you want it more sensitive, you can decrease it. You can make it 0.4 or 0.3. Or less sensitive 0.6 or 0.7 microvolt. Then you need to set the beep, and this is as usual, but you can use the function of EDI minimal. So if you have high EDI, for example, more than 3 microvolt, that means the baby requires more beep. So you can increase the beep and you set the EDI minimal again. You need to set the FI2, and then you need to set the NAVA level. So what is NAVA level? NAVA level is a conversion factor that converts the EDI signal into a proportional pressure. That means how much the proportion of work done by the ventilator to unload the respiratory muscle of the baby. NAVA level equal delta BIB divided by delta EDI. So if you have patient who has already on ventilator and you know his effective BIB and you shift it to NAVA level, you can use this equation to calculate the NAVA level. So by dividing the delta BIB by dividing the delta BIB by delta EDI. The adequate NAVA level usually keeps the EDI peak between 5 and 15 microvolt. If you have an unit, you don't know what is his effective BIB, or you just set him on NAVA ventilation as a primary mode of ventilation, then you need to adjust the NAVA level. You start by 0.5 or 1, and then by NAVA level 0.5 or 1. And then you look to the BIB and you look to the EDI peak. And you keep increasing the NAVA level by 0.2 or 0.5 till you reach a point that the BIB is static, is not increasing, and the EDI is decreasing. This we call it the break point, which is usually the adequate NAVA level, or the level you have to target for. Then you need to follow this EDI, and you need to follow also the clinically the work of breathing of the baby. So if the EDI is increased or the baby is working hard, you can increase the NAVA level to unload the respiratory muscles of the baby more. Then you need to set the backup mode. If, as we mentioned, the NAVA is applicable whenever you have EDI signal. So if EDI signal is not detected and patient is apneic, the baby will switch to backup ventilation. So you need to make sure that your backup ventilation setup is adequate for the baby. So you need to set up with appropriate PIB, eye time, and respiratory rate. Then you need to set appropriate alarm time. And most important, you need to set apnea time. So what is apnea time? Apnea time is the maximum time that the neonate will be without any ventilation. So if you set the apnea time, for example, say 5 seconds, your baby on NAVA ventilation mode, then he lost the EDI, he's apneic. So he remained 5 seconds without NAVA ventilation because there's no EDI signal. And also he's waiting on this 5 seconds before switching to the backup mode. So you need to be very cautious when you set this apnea time. As recommended initially, set the apnea time is a little bit low, like 0.2 or 0.3, till you assess the breathing function of your baby. And then later on, by following the trend, you can extend the apnea time. After setting the, adjusting the setting for NAVA ventilation, then you need to observe the, after 1 or 2 hours, and probably frequently you need to assess the trends of ventilation in the screen of the ventilator. So there's 2 trends, number of switches to backup per minute, and number of, and the percent time of patient being on the backup. We start with number of switches to backup per minute. So if your baby is stable, that means his saturation is okay, blood gas is fine, but he's going very frequent with high number of backup per minute. So that means your apnea time is short, and this baby can tolerate more apnea time, so you can increase the apnea time. If your patient is desaturated or had blood gas not with accumulating CO2, and he's frequently going to backup rate, so probably your apnea time is long, so you need to decrease the apnea time. If your baby is stable and he's not switching frequently to backup per minute, so that means your baby is stable. You can increase the apnea time, and by this you can wean the baby also. Also, you need to check or to follow the percent of time in the backup ventilation per minute. So if you have a patient with low number of switches to backup, but when he switches to backup, he's remain for a longer period on backup mode. So probably this patient is not ready for weaning, and probably is not ready for weaning. So still he need special support. If the number of switches to backup is low, and also when the baby switches to backup, he stays for a short time and then he comes back to NAVA mode, then probably you can wean this baby by increasing the apnea time. And if you have patient had high number of switches to backup, and also when he switched to backup, he remains for longer time there, so you need to increase the apnea time in this situation. Then after following the trend, and also you need to follow your patient as any mode of mechanical ventilation, you need to follow the target saturation you set for the baby, and also the blood gases. If the neonate is ventilating in backup frequently, consider increasing either the backup rate or peak time. So if you have a baby who's on NAVA ventilation, he is not maintaining the acceptable saturation, or he's accumulating CO2, and he's going frequently to backup. So most likely the setting you put for the backup setting is not adequate to support this patient. So you need to consider to increase the BIB, to increase the rate, or to increase the I time. So you need to optimize the backup setting. If the neonate is working hard to breathe, this retraction, this high EDI signal, then you need to consider increasing the NAVA level. So to give the ventilator more work to do to upload the respiratory muscle of the baby. And again, if the neonate is setting off the high pressure alarm, that means the baby required more BIB, and you are limiting that BIB, so you need to consider increasing the peak pressure limit to allow alveoli recruitment and improve the tidal volume. Weaning off NAVA ventilation, again, you will use you assess the patient clinically and use the trend screen to follow BIB, the respiratory rate, number of backups per minute, and the time percent in backup. If the patient is clinically stable, you need to consider increasing the apnea time, decreasing the backup setting, decreasing the NAVA level to load the respiratory muscle, and then eventually you can extubate to NIV NAVA. Non-invasive NAVA, this works like NAVA, but it's able to assess the patient non-invasively, as you know. But the setting is the same. You need to set the EDI trigger. You need to set the beep, FI2, NAVA level, and also you need to set the backup. Non-invasive NAVA appears to function well with leak as high as 90 to 95%. So this is understandable because you are not dependent on the flow sensor. You are detecting the electrical activity of the diaphragm. So the leak is not affecting the synchronization of this breathing baby to ventilator. Contraindication to NAVA, actually it's not contraindication, it is it's not contraindication, rather than it will be invisible in this condition. As we mentioned, you need intact electrical signal from the brain to the diaphragm. So if you have insufficient or absent respiratory effort, like brain anomaly or heavy sedation or paralysis, obviously NAVA is not going to work. And if there's congenital anomalies like esophageal atresia, that means you cannot position the NAVA catheter to take the electrical activity of the diaphragm. Severe diaphragmatic hernia, NAVA in diaphragmatic hernia, still you can get some electrical activity, but you need to assume that the electrical activity, you get it from that part of the diaphragm, it represents the whole diaphragm. So it's relatively contraindication. Phrenic nerve injury, congenital myopathy, and MRI. MRI, the NAVA catheter is not compatible with MRI. So if the baby is going for MRI, you need to remove the NAVA catheter, and then after you finish the MRI, you can insert it back. Evidence base for NAVA for using NAVA in the NICU. Actually, this is two Cochrane library review for assessing NAVA in the NICU. The first one is by Rosa and is published on 2017. It's about neurally adjusted ventilatory assist compared to other forms of trigger ventilation for neonatal respiratory support. So the primary goal or the primary objective for this Cochrane is to determine whether NAVA, when used as a primary or rescue mode of ventilation, results in reduced rates of bronchopulmonary dysplasia or death among term and preterm newborn infant compared to other form of trigger ventilation. And also to assess the safety of NAVA by determining whether it leads to greater risk of interventricular hemorrhage, periventricular leukomalacia, or air leaks when compared to other form of trigger ventilation. Also, the secondary objectives, they want to determine whether benefits of NAVA differ by gestational age, term or preterm, and to determine whether outcomes of crossover trials performed during the first 2 weeks of life, including peak pressure requirements, episodes of hypocarbia or hypercarbia, oxygenation index, and the work of breathing. There's only one randomized control trial, which is eligible for this review. This is the neurologist ventilatory assisted preterm newborn infant with respiratory distress syndrome randomized control trial by Calio, and this is published in 2016. So the result, no significant differences in duration of mechanical ventilation, nor in rate of bronchopulmonary dysplasia, pneumothorax, or interventricular hemorrhage between NAVA and patient-triggered time cycle pressure limited ventilation. They reported lower peak respiratory pressure in the NAVA arm. So the author concludes that the risk and benefits of NAVA compared to other forms of ventilation for neonates are uncertain. Well-designed trials are required to evaluate these new forms of trigger ventilation. The second Cochrane review is by Joel, and this was published this year. It's about diaphragm-triggered non-invasive respiratory support in preterm infant. The objective of this Cochrane review is to assess the effectiveness and safety of diaphragm-triggered non-invasive respiratory support in preterm, less than 37 weeks gestation, NIV-NAVA, when compared to other non-invasive modes of respiratory support, NIBBV, nasal CPAP, high-flow nasal cannula, and to assess preterm infants with birth weight less than 1,000 grams or less than 28 weeks corrected gestation at the time of intervention as a subgroup. The result, again, there is only 2 small randomized controlled trials, including a total of only 23 infants eligible for inclusion in this review, and also showed no difference in failure of modality between NIV-NAVA and NIBBV. And the author concludes that due to limited data and very low certainty evidence, we were unable to determine if the diaphragm-triggered non-invasive respiratory support is effective or safe in preventing respiratory failure in preterm. NAVA, or neurally adjusted ventilatory assist, and non-invasive NAVA are gaining recognition as functional modalities for neonatal ventilation. The EDI signal provides the clinician with previously inaccessible information about central respiratory drive, useful for both weaning and diagnostic. It appears that NAVA works in neonates, but the question remains if NAVA makes a difference. So obviously, more randomized control trial is required. This is my references, and thank you very much for listening.
Thank you, Dr. Ahmed, for a lovely talk on NAVA. Thank you and have a good evening.